So good afternoon. We are excited to welcome you to today's webinar on our groundbreaking medical technology that has the potential to transform lives and breathe new hope into the world of respiratory care. My name is Cody Tobos, and I'm honored to guide you through this journey into the world of diaphragm pacing. The human respiratory system is nothing short of a miracle, allowing us to breathe effortlessly and continuously day in and day out. But for those who face respiratory challenges, each breath can be a monumental effort, often requiring the use of traditional ventilators. In these situations, the NeuRx diaphragm pacing system emerges as a game changer. Traditionally, many people with compromised respiratory functions rely on mechanical ventilation, which comes with its own set of limitations, such as restricted mobility, infection risk, and the emotional toll of being tethered to a machine. But today we're going to explore an innovative solution that offers new hope and a breath of fresh air. Diaphragm pacing is cutting-edge technology which has the potential to liberate individuals from the constraints of mechanical ventilation. By the end of this webinar, we hope you will gain a profound understanding of how diaphragm pacing is revolutionizing respiratory care and how it can provide new horizons of hope and independence for those who need it the most. But before we embark on this journey, let me introduce our panel of experts who will be guiding us through today's discussions. Each of them brings a unique perspective and wealth of knowledge on the subject. So, without further ado, please join me in welcoming Mary Jo Elmo. She's a nurse practitioner at University Hospitals in Cleveland, Ohio. Emily Zona. She is a licensed master social worker at Prisma Health in Columbia, South Carolina. And Erica Mason, Director of Respiratory Therapy at Millennium Post-Acute Rehab in West Columbia, South Carolina. Also joining us will be Lynn Brandt-Purpley, Respiratory Therapist and Clinical Specialist representing Synapse Biomedical in our Southeast region. She will be here to answer any questions on Synapse's clinical role in diaphragm pacing. So right now we're going to go ahead and let Mary Jo get started. I hope everybody enjoys.
Hi, thank you all for having me here today. I've been working with diaphragm pacing since 2004. When I started at this hospital, there were only 4 patients who had the device, and we have now implanted over 906. So there's been a lot of changes with it. So for those who don't know, diaphragm pacing, is there a way to get rid of that? Is an aid to diaphragm. Sorry, I'm just working with the slides. I'm going back one. All right. So essentially a diaphragm pacemaker, for those that know, is another type of machine, but it's not quite like a ventilator, where we put wires or electrodes into the diaphragm muscle, and it's something to help you breathe, either decrease delay or replace mechanical ventilation. This presentation is going to stick to the FDA approved indication, which is for essentially quadriplegics, high-level spinal cord injured patients that require mechanical ventilator. And while we here at University Hospitals do some off-label use, if anyone's interested, they can call me directly to hear about that. Again, this presentation is focusing on the FDA-approved indication for the pacemaker. We've started this pacemaker thing, it actually dates back to the 80s in clinical research. There have been a bunch of studies and trials with it. It's not brand new. And I know some people say I've never heard of it, but there is a lot of published data on diaphragm pacing. We at our hospital have 14 different IRB protocols. We also have FDA approved indications. And again, I said there's over 900 that we've done just at UH, and that number is 2,000. It's probably closer to 3, but Cody would know that. So like I say, there's been a bunch of published peer-reviewed articles and book chapters on diaphragm pacing. So it's not new, and it's something that's been around. It just may not be familiar to you. The reason it's such a big deal in spinal cord injured is that if you are injured at the level above, especially above C3, 4, 5, it is where you actually will start to get significant respiratory compromise. And almost anybody who has an injury, even if it's incomplete above the level of C3, will require a mechanical ventilator. Mechanical ventilators are incredibly expensive. If you're a vent-dependent quad and you live that first year, your care averages about $1 million a year. ICU care for ventilators is very expensive compared to non-vents. So when you're a spinal cord injured patient, your highest mortality is related to pneumonia or pulmonary complications. When you're on a ventilator, your highest complication is pneumonia or pulmonary complications. So if you are on a vent as a spinal cord injured patient, you have a double whammy of really having a lot of pulmonary complications and a high death rate. It is the biggest reason that quadriplegics actually will die is respiratory related. And unlike other diseases and other illnesses, and this includes other things in spinal cord injury, survival when you're on a ventilator actually decreased, compared to like 20 years ago. It's kind of plateaued again, but there were like a several year period about 4 years back where the life expectancy of a ventilator dependent quad went down. And that is because, it's just harder and harder to find places to care for vents and technology, and people are just not that into it, home nursing as well as facilities. And there's this thing that's also called ventilator-induced diaphragm dysfunction. I just bring it up because even levels of spinal cord injury where people should be able to breathe, if you're on a vent for other reasons or just initial weakness, the longer you're on the vent, the harder it is to get off of it. You may have heard that phrase, the longer you're on the vent, the longer you're on the vent. And that is because once you're on a vent for a certain amount of time, and really you start to see muscle atrophy in just as little as 12 to 24 hours of being on positive pressure ventilation. So this thing called diaphragm pacing, your diaphragm is your main breathing muscle. And what it does is it controls about 70 to 80% of our ventilation. And essentially we breathe, electrical impulses go down from our brain to our spinal column. And at the level of C345, there is a nerve that branches off a right and left phrenic nerve that make the right and the left diaphragm muscles contract. And you can see air, when the diaphragm contracts down, the air gets sucked into our lungs. So when you're on a ventilator, if you have spinal cord injury, those get affected and your diaphragm cannot move. And if you have a complete injury, then it doesn't matter how hard you try or if you can use your accessory muscles. If 80% of your breathing is gone because the diaphragm doesn't work, it's going to be very difficult. You'll never really get off a ventilator. So I'm going to stop this for a second. So that's where this whole thing for diaphragm pacing comes in. We can take people who have spinal cord injury that cannot move their diaphragm and put in this device and make their diaphragms move. It will not work for all people, and we'll get into that a little bit. But the very first thing we do when we have a spinal cord injured patient is we really just determine their safety, surgical safety. And if they are safe to go to surgery and get a surgery that's very similar to laparoscopic gallbladder surgery, what we do is we take them to surgery and we just see whether or not we can make their diaphragm move. So in this video, see, that is a view of a diaphragm. It's as if you had your head and your stomach looking upright, and we're just looking for diaphragm movement. So that was the right diaphragm. This is the left diaphragm. And we're just looking to see if the diaphragm muscle will contract. If we get contraction like that, and when a patient is breathing, they're not moving their diaphragm on their own, then it's reasonable for us to say, we can implant these wires and move your diaphragm when we know that you can't. So this is essentially what the wires look like when they get implanted. But essentially, this is what you have when you have two wires and we get this big diaphragm movement. That simulates what a normal person would be doing when they're breathing. If you have spinal cord injury, impulses aren't getting through and you can't do that. So once we implant these wires, this is what the box looks like, and we can control and power each individual electrode. We get 2 electrodes, 2 to the right diaphragm, 2 to the left. And like I say, while they all go off at the same time, the actual individual power to the electrodes can be individualized. If somebody has maybe an incomplete injury, more sensation on the right or left, it can be tailored to their needs so that we can make it comfortable and still give them a big diaphragm contraction. So I had said earlier that this all started years ago. Some of you who are older may know Christopher Reeve. He was one of the big Supermans back in the 70s and 80s. He fell off a horse and he was a complete C2 quadriplegic. And he was number 3 in our clinical trial. That's not a HIPAA violation because he went and did a whole huge press conference about it. So again, if you have a high-level cervical spinal cord injury, you are going to require tracheostomy mechanical ventilation, and that changes your overall care, complexity of care, and life expectancy. And like I say, so it's been done. We did our first original clinical trial. The first patient was implanted in the year 2000. The clinical trial was over in 2008. And what we had in that clinical trial, there was one patient that went to surgery and he had dead diaphragm. So he did not get he got the wires and then they realized the diaphragm wasn't working. But for all of the other 49 out of 50, there was 100% success on getting patients to breathe for at least 4 consecutive hours off a ventilator. So, with diaphragm pacing, they were able, patients preferred it. That was across the board. They had decrease in secretions. They had improvement in life satisfaction. So it was, a good thing. But since that original trial and data that was published back in 2008, I'm going to go over a couple of the newer trials that have been, or clinical reviews that have been published recently. So in 2018, we kind of did a review of what our patients were doing. And again, this does include this paper included some pediatric patients because we do implant those, but that's an off-label use. So you can see in our patients that were pacing at least 4 hours a day, we had an 88% success, and there was a median survival of 22.2 years. So again, most of our patients, if we can implant you at the time of surgery, most of them will get off their ventilator part-time. Over half, 61%, are able to replace their ventilators 24/7. And some of those patients were actually able to then wean off of pacing because electrical stimulation can help with recovery. I know this is a very busy slide. I did it this way so you can at least see all of the stuff. If somebody wanted a copy of it, they can have it. These are papers that were published by Kerwin. And essentially they showed that, in total, diaphragm pacing improved mortality. It decreased ventilator days, especially if you had pneumonia. It increased and improved respiratory mechanics. So, for someone who was using a pacer, they were able to improve their tidal volumes alone, just because pacing is a form of electrical stimulation therapy. So while it does replace a ventilator, and for some people that is all they will ever use it for, this is what I use to breathe instead of a ventilator via tracheostomy. For some people, it just helps them improve respiratory mechanics, where they can then get rid of their tracheostomies because they can work with accessory muscles, or it will then help with recovery and they can get rid of the pacer altogether. This is from another paper that was published in 2014, and essentially it shows some benefits of early implantation. So one of the things, like, they took this group of patients, this was a multi-center trial where they are review, and they took a group of patients to surgery. So yeah, there was some great stuff for the people who were able to be implanted. Like they showed, like, look how many got weaned, they got off their ventilators, which is much better compared to historical controls. But one of the things that's really important to know is that there were identified 24% of the patients that they took to surgery were not able to be implanted because their diaphragm muscle did not respond to stimulation. And the reason that that is so important to know is that if we can't move your diaphragm, your brain's not moving your diaphragm, there is no point on continuing to try and wean someone off a ventilator. I mean, you might get off 20, 30 minutes at a time, but you will never be able to be fully vent-free. And then once that's identified early, your trajectory of care can alter and change from I'm going to try and wean over and over and over and fail to wean. Having people say, relax, it's okay, it's anxiety, when you really are moving no air because your diaphragm doesn't move, to you're going to be living on a ventilator, and let's alter your care to, essentially standard of care quadriplegics, which is high tidal volume ventilation. Even though you're on a vent, you will go to a cuffless trach, start eating, just change that trajectory so you don't have to go through those months of failure to wean. And it's not like it's a failure of desire. It's just you can't do it. So again, and then this is one of the most recent things that's included in best practices for spinal cord injury, and from the trauma people and their groups that, they reviewed the data, and it's in there now, guidelines that diaphragm pacing should be considered for all spinal cord injured patients because of the reasons I said: respiratory mechanics, decreased wean time, decreased hospital costs, and length of stay. This will go to who should be implanted. In our clinical trial, we used to do phrenic nerve conduction studies under fluoroscopy to confirm that the phrenic nerve would actually respond to electrical stimulation therapy. We here no longer do that. We published a paper that demonstrated that the phrenic nerve conduction studies were wrong as much as 50% of the time, false negative and false positive. So that's why we don't do them anymore. We mostly just take someone to surgery as long as we feel they're a good, safe surgical candidate, meaning we can take them to surgery, wake them up, and get them in their same current condition, regardless of whether or not they were implanted. Level of injury, some people, I've heard people say, oh, well, he's a C4-5, he can't be implanted because the motor neurons to the phrenic nerve have died off. Well, that's not always true either. About 20 to 30% of our patients have C3-4-5 involvement where the motor units to the phrenic nerve are. So we just never know if someone will be able to be implantable until we go to surgery and do that stimulation. Some of the benefits of early implantation is we have been able to avoid tracheostomy in some patients. May not work for all patients, but this was a kid, he's off label because he was under 18, but so just forget about that for, the synapse people. He was implanted. He failed 2 extubations, and after about 3 weeks, we implanted him. It was actually day 22 post-injury. He was a C3-4-5 that we implanted him. After 2 days of being implanted, we extubated him. And then over time, took about 3 or 4 months, he was then able to get weaned from the pacer. So, he was really thrilled. It changed his whole trajectory for physical therapy and rehab to be there without being tethered to the ventilator. So again, anybody, any spinal cord injured patient who requires the assist of mechanical ventilation, even if it's not 24/7, should be considered for all of those reasons we just said, as far as, we can improve their overall ventilatory status. I think Emily is going to talk next, and I'll be around at the end if anyone had questions.
Hey guys, I'm just working on getting this pulled up. Give me 1 second. There we go. Okay, so can everyone hear me well? My name's Emily, as Cody mentioned. I'm a social work case manager at Prisma Health Richland Hospital in Columbia, South Carolina. I've worked here about 1.5 years, going on 2 years, and I work in the surgical trauma intensive care unit. So I do work closely with our trauma patients, spinal cord patients. Prior to working in the ICU, I still worked with the trauma population. I was just on the regular trauma floor. So now I get to see kind of in the ICU how to start the discharge plan and how to kind of help carry that through as they move to other floors. So I'm going to be talking about diaphragmatic pacers from a case management perspective. So the first thing that I want to mention, case management right off the bat, any spinal cord injury that we get, we immediately get consulted we know right away that they're going to need some level of assistance, some level of support. So the first thing that we do is we assess these patients, we determine the level of family support that they have in the home, and we work towards establishing a plan, whether that's rehab, long-term care, whatever they need, kind of depending on family support, insurance, a couple different factors. If they have a diaphragmatic pacer, things can get a little tricky. Unfortunately, most services will not assume the care of these patients. So that's kind of a barrier that we've faced when dealing with these patients. No home health agencies in the state of South Carolina will take on these patients, as well as the HASKI program. I'm not sure if you guys are familiar with that. It's the Head and Spinal Cord Injury Program. They also will not assume the care for these patients. And that is a big resource that we do provide to all of our spinal cord injured patients. But unfortunately, with our diaphragmatic pacer patients, it is not an option, as well as private agencies and most rehab facilities will not assume the care for these patients either. And that's solely due to lack of education and training on these patients. They're just not willing to take responsibility. So moving forward, who will assume care? So luckily there are limited options, but we do have some options. Shepherd Center, as I'm sure most of you guys are familiar with, is a short-term rehab facility in Atlanta, Georgia. They will take our pacer patients for short-term rehab. So we work closely with the liaisons there at the facility to help kind of coordinate that and facilitate that. Through those discussions, we have discovered that they as well do have great difficulties discharging those pacer patients back home due to the lack of resources in the home setting. Another option that we do have for our pacer patients is Millennium. It's a skilled nursing facility here in Columbia, South Carolina. It is the only skilled nursing facility in the state of South Carolina that will accept patients with pacers. So we work closely with Millennium, Diane over at Millennium. We work closely with her to help get our pacer patients long-term care. So what should be done? I believe that it really needs to be addressed at a higher state level. I don't feel that it can be thoroughly addressed at a single hospital level. I feel that there needs to be education and training done with the South Carolina Hospital Association, DHHS, state legislators, home health agencies, as well as the HASKI program. And they need to understand what the need is, what needs to be addressed, and why it's such a necessity for these patients' recovery, as well as understanding what exact resources are needed to provide care for these patients. And that is it. If anybody has any questions, feel free to ask them when everybody is done presenting.
Thanks, Emily. Next, we'll have Erica Mason from Millennium join us and present her information.
Good afternoon, everyone. So my name is Erica. I'm the Director of Respiratory at Millennium Post-Acute Rehab. We do accept diaphragmatic pacer patients. We went through and we created a partnership with Richland because of them having the issue of having their patients or having difficulties placing their patients. So I'm going to go through and do a case study for our resident, one particular resident that we had here that kind of slipped through the cracks because, again, as Emily stated, the lack of education in a lot of the facilities. So is to consult or not to consult? This patient actually had a positive outcome from being caught early and being placed on the pacer. So what is Millennium Post-Acute Rehab? We are a long-term / short-term facility who provides care to short-term rehab, long-term rehab, long-term ventilator and trach patients. We are currently one of the only long-term facilities in the state of South Carolina who accept patients on diaphragmatic pacers, also long-term ventilators. Who am I? As I stated earlier, I am the Director of Respiratory here at Millennium. We currently have 2 diaphragmatic pacer patients who came from Richland, who's currently in-house. One of those patients is actively weaning. The other one, we're going back and forth, but we have been able to give them both some sort of quality of life. One of our pacer patients, he's off the vent during the day and is able to eat, while the other one is on the vent continuously on pressure support, and he's able to eat as well. All right, let's move on to the study. So we had a 50-year-old female with a history of depression, anxiety, alcohol dependence, substance abuse, and she was a quad. She was found on the front porch by her son after a suspected fall due to ingesting Percocet and wine. When her son found her, called EMS, had her taken to the hospital. She was noted to have a C3 and C4 fracture. She had an ACDF done of C3 and C4 and C5 through C6. Patient, prior to having this surgery, she was having complaints in the ER stating that she was not able to feel her upper or lower extremities once she was a little more responsive from being found down. Ultimately, the patient had numerous issues during her hospitalization. Ultimately, she had to be trached and pegged. And prior to her hospitalization for this incident that occurred, she had been to the ER 2 different times with complaining of right-sided neck pain. So once she got to Millennium, she admitted to us on October the 17th of 2022. We attempted to wean the patient on several accounts and was unsuccessful. So at that time, I reached out to the pulmonologist who was seeing her previously after speaking with the nurse practitioner who we have here, who follows our vent and trach patients. So reached out to the pulmonologist just to kind of see where their mindset was for her and what plans they had for her. And just wanted to know, out of curiosity, why was she not a candidate for a diaphragmatic pacer? Because she seemed like she was the perfect candidate. At that time, the pulmonologist stated that he was not very familiar with it. So it was almost like she basically slipped through the cracks. So after having the conversation with the pulmonologist, I went in and provided the information to the patient and the sister, provided them with as much education as I could have possibly given them, and just wanted to know if they wanted to sit down and, coordinate, what did they want me to coordinate, having her seen by the trauma surgeons to see if it was even an option for her. So I reached out to David Dunlap over at Prisma, who has been phenomenal with working with us, educating, and just having an open line of communication. I reached out to him and kind of gave him the scenario as to what we had going on. And he was able to reach out to the surgeons to actually get her a consult, since we thought she would be a great candidate. So it was a teamwork effort. David reached out to Dr. Hesse and Dr. Watson, communicated the patient's history, provided the patient's information to David. She was already in the Prisma system. So the surgeons were able to fit the patient in for an appointment. Unfortunately, the patient ended up having an acute issue here. But from communicating, we were able to get the patient sent over to Richland, since we already had an appointment for her consult with Dr. Hesse and Dr. Watson. So we got her sent over to Richland for her acute issue, and then we could have had her seen while she was there for her diaphragmatic pacer consult. So while there, the patient was actually able to receive the pacer. She was able to be weaned from the vent. Her trach was capped, and she was able to actually discharge home. She did keep her trach and her pacer at the time, but she was on a diet. And like I said, she was able to go home. She was to follow up with the pulmonologist and primary care provider to determine decannulation. David actually allowed her to FaceTime me the day before she got ready to go home. And she was just so very thankful because no one gave up on her. And we actually gave her some of her quality of life back. And that patient actually is still alive. She's doing well. She is, I can't remember if she still has her pacer or not. She doesn't, she was actually decannulated. She's still on her diet. She has a motorized wheelchair now so that she can maneuver. But, you know, with teamwork and communication, we were actually able to assist this patient early on and actually give her some quality of life. So that's what it's all about. So that is all I have. If you guys have any questions for me, again, please don't hesitate to ask.
Feel free to send anything in the chat if you don't want to speak up. Any questions you may have, I'll monitor that. But I'll get started with one question I just have based off of Emily and Erica's conversation. Emily, you mentioned some barriers in South Carolina. As far as finding placement for these patients. Now, I know you have a system kind of worked out with Millennium and the other facility that's escaping me right now. But how were you able to set that up with those facilities to make sure that these patients could be placed? Was that something you guys did, or was that something that was offered to you, and kind of, do you have any suggestions on ways to get over those barriers right now?
Yeah, that's a good question. As far as I know, I don't know that we had any direct like education with Shepherd Center for the Pacers. They just happened to take Pacers. I know for Millennium, our respiratory therapist, David Dunlap, I believe did the training for them. He was comfortable doing it with them. So I believe that is kind of how Millennium got involved, is through the training that David provided to them.
Okay, great.
And I do know that it was kind of in the works that our own Prisma Home Health currently doesn't take pacer patients as well. Last I heard, it was kind of in the works that he was going to be training them as well to take on some pacer patients, but I'm not sure if that kind of fell through the cracks or what the update on that is.
Yeah, it seems like there's a champion in every facility that kind of sees the power that this device can offer, and that's kind of where we're at, is looking for those champions at different facilities. There's a question here. Is there any protocol or standard for weaning from ventilator to diaphragm pacing? If Lynn or Mary Jo want to hop in on one of those.
This is Mary Jo. I can tell you our personal recommendation. We do weaning differently, depending on whether or not you're weaning in a facility versus you're quadriplegic at home with personal caregivers and family that will be weaning you. And there was an article that was published. Janet Dean was the primary author, and we actually go into it's focused on peds, but we go into the different ways that of these two ways of weaning. So if you're weaning in a facility, our recommendation here is that you just put the pacer on to the highest settings the patient can tolerate. Sometimes that may mean adjusting settings a few times, but you just keep the pacer on 24/7, and then you would wean the vent as you would for any other patient. Just pretend the pacer's not there. So there may be good days or bad days, good hours, bad hours, but eventually, like our facility and the facilities here in Northeast Ohio do a lot of pressure support weans where they'll go from full vent support to pressure support, decrease and decrease pressure until you're essentially just on 5. And then they'll start doing trach collar trials and increase the length of the trials until you're off 24/7. And that's essentially what they do most often here, and what our recommendation is. That's what they do in Baltimore with theirs. If you are weaning at home, parents don't really have that ability to go in, or husbands, wives, to always adjust the ventilator settings. So what we do is we just have the pacer, and then they just start doing, we call it sprinting, where you just remove the ventilator and that might be 1 minute to start. It might be 30 minutes. It really depends on where the diaphragm and how much tidal volume you get to start with. So if you're like 140 pounds and you get 500 cc tidal volume, you might go 2 or 3 hours your first time off the vent, and you may do that multiple times, and you just sort of increase the amount of time every few days, and you do the usual monitoring that you would for any other vent wean. So the need for suction, pulse ox, all of those sort of things, that all stays the same. So those are the 2 ways that people can wean, is sprinting off the vent, or just doing your traditional wean where the pacer's on all the time and you just decrease vent support, however it is you would normally do it for any patient.
Cody. Hello, it's Lynn. I just wanted to let everybody know that's on this that we do have clinicians that we will gladly go and train at facilities. If it's necessary, there's no problem. We just schedule our time. And so if you have a facility that needs training, please reach out to somebody at Synapse Biomedical, and we'll gladly arrange to get someone there to train your staff.
Hi, I just had a question about the, I think you said it was the EMG studies where you found false positives and false negatives. Can you reference that study? Is that something we can look up?
I'm sorry, what was that question again?
The question was for Mary Jo. Mary Jo, did you hear that?
It was about the EMGs getting the false positives and the false negatives. So when you would test for contraction and you stopped doing that, I was just wondering if you could reference that study. Is that something that could be looked up?
I'm sorry, this is Mary Jo. I gave the entire answer muted. I thought that the paper was listed in the PowerPoint. Yeah. So in the PowerPoint on slide 13, it was published in the American Journal of Surgery. So it's the American Journal of Surgery 2021. I don't know if it's volume or whatever, 221, pages 585 to 588.
Great, thank you so much. I appreciate that.
Mary Jo, I have a question for you. The success rates with discontinuing vents or trades and the pacer all together, what has your success rate been with that? Here we have learned that when we wean the pacer and the trait, the patient typically doesn't they don't have a good success rate versus if we wean the pacer and leave the trait. So considering you've been doing this for a while, is there any advice you can give me with that, or tell me some things that you've saw?
When we do it here, or if it's being done under our care supervision, when we will leave the pacer on until the patient is actually ready to have their trach come out. So the pacer stays on all the time, 24/7, until and then the trach comes out when they meet the usual criteria. So there may be isolated individuals that because of secretions will never come out, but we will like downsize the trachs until they're at a 4 or 6 Shiley cuffless, because we do know that the smaller the trach, trachs themselves, the mere presence of it creates secretions. So the cuffless you go, and the smaller you go, the less secretions that will generate on its own independent. And we make sure that they're able to manage that, get that, then be able to breathe cap 24/7, manage with a cough assist. Like we do recommend patients use cough assist, and they will use cough assist with the trach capped over their mouth to make sure that they can manage secretions that way. Then the trach would come out, and then we would see if they're able to wean from pacing. We actually, depending on whether or not they actually have, so the patients that we're taking trachs out and then possibly weaning from pacing, these are people who do have spontaneous diaphragm activity. It is not just like a complete C2 quad that doesn't. For us to remove a trach on a C2 quad that doesn't, they have to have the ability to demonstrate that they can move and breathe with accessory muscles for at least 1 or 2 hours on their own in the event of a pacer failure. So we go very cautiously. We make sure that they actually meet all their criteria for getting the trach out. And sometimes that may fail. And it's usually not because of a tidal volume thing. It's usually because of a secretion issue thing.
Yeah, that's exactly what I was looking for, because that is exactly what we've ran into. In the beginning, secretions, we are not doing a lot of suctioning. So we are getting the pacer pulled, and then we pull the trach. And then after we pull the trach, the patient continuously had recurrent pneumonias that kind of made healing or, trying to gain any kind of quality of life a little bit challenging for him.
With spinal cord injured patients, we are very big believers in utilizing cough assist. And even when the patient is healthy and has very little secretions, we believe that cough assist should be done routinely twice a day. And then if they're at a time where they have increased mucus production, then doing it more, and that will help and decrease the amount of secretions. And we will also use a very old piece of equipment called a hood stoma stent, and that has an opening for suctioning, but it's very small, so it doesn't create the same kind of secretions that the presence of a trach will, and you don't see it because it's very tiny. So you can Google and visualize what a hood stoma stent is. And we've had a few patients that have had great success with maintaining their stoma open in the event of emergency. That can be pulled out and a trach replaced. And then it is an avenue for suctioning if it needs to be.
Oh, wow. I will surely look that up.
So I saw that there were some questions in the chat. I don't know if there were other questions first, and then I can address some of those in the chat. Cody, is there anything else?
I don't see anything else.
Okay.
One person is asking, is there any evidence about pacing unilateral diaphragmatic eventrication?
Yeah. So that's an off-label use. And let me answer the question before that first. And that was about education opportunities for fellows. So Dr. Anders or myself present almost every single year at ASIA, which is American Spinal Injury Association Conference, ISCOS, which is the International Spinal Cord Conference, and ASCIP. Well, it's not actually, ASCIP is for the nurses, but the Academy of Spinal Cord Injury, yeah, it is. It's ASCIP, Academy of Spinal Cord Injury Professionals. So we do present information at that. And there's, like I say, there is a bunch of stuff that is published. You can always email me and I can see specifically what you're interested in or put you in touch with other people if you wanted to talk to a third party about pacing. But we do have those articles that are published that can and help you. But like I say, we do present at conference and stuff that's published. So as far as unilateral diaphragm paralysis, we have paper, it was published back in 2014, but then there was presentations, there are abstracts that were published with presentations at AASD, which is American Academy of Thoracic Surgeons, and then the International Lung Transplant Meeting. I know it's like IHLTS. So we have been implanting for just unilateral diaphragm dysfunction, whether it be idiopathic or post cardiac surgery. We've had from shoulder injections, COVID infections, shingles virus, multiple reasons. There have been about over 300 or so of those patients implanted. Again, this is an off-label use, so Synapse really can't discuss this with you. You can always call me and I can discuss it at my office, but we have about a 70% success rate with getting people better. So in that 70, we have 35% that get complete recovery, like correction of unfluoral, correction of chest x-ray, recovery of EMG, baseline symptoms. Then we have 35% that kind of fall like a plication would, where they are improved. And there's still about a 30% failure rate of people that we implant that after a year and a half to 2 years, they still don't get recovery. We do know that earlier implantation is better, but we still have that 70% recovery rate for people that have been implanted or injured for between 2 and 5 years. Once you've had a unilateral injury for 15, 20, 30 years, those people really just don't really respond well to pacing. So while there's only been one paper on our initial patients published in 2014. We've had several abstracts that were published or presented at some of the big thoracic and spinal cord injured meetings, heart transplant, LVAD meetings that showed the data from that.
Mary Jo or Lynn, either one of you guys can answer this. Have you ever thought of coming, since we have such a deficit in South Carolina, they hold an annual respiratory convention every year. Have you guys thought about coming to that convention maybe? To do some education as well, because they do have a lot of the major facilities here there when they come, and maybe do some education that route. So therefore, we can communicate it well in South Carolina. Because if I'm not mistaken, MUSC in Charleston also places diaphragmatic pacers.
No, first of all, yes, I would be more than happy to do that if you'd like to send me the information. MUSC does not do pacers yet. I am in contact with the trauma surgeon there. And Trident in Charleston is also, I have a trauma surgeon there interested, and I did a presentation at Trident Medical Center. But I would be more than happy if you send me the information. I would be more than happy to attend or get a speaker or whatever. So let's talk.
Will do.
There's another question here about the occurrence of electrode wire broken or infections.
All right, so as far as wire breakage, this is an external system. I'm not even sure we showed a picture of it, so I apologize for anyone who hasn't. If you go to Google Images, you can see it. But so this system is external. There are wires that will break. When you see this, it makes sense. If you don't know, if you don't actually see a picture, it kind of sounds weird. But you have, your skin, low chest, high abdomen. Wires come out of the skin like hairs, and those wires go into a little piece of plastic. And on the other side of the plastic are little pins, and then it just plugs in like your cell phone plugs in. There's a box, the cable, and that cable connects the box to the wires in the person. Where those wires go into the plastic, where they go into those pins, Those will, in the spinal cord patients, they actually don't break very often because they're not moving around as much. In our off-label patients that are still working and active, there's some more breakage, but those are external breaks and they're actually not that difficult to fix. It doesn't require anesthesia or surgery. They can be done. It's very electrical work where you cut the wire, put a new pin, pop it in the block. And it's actually not as bad as it sounds. As far as wires that have broken under the skin, in the 906 patients that we've done here at UH, there have been 3 people who have had a solitary electrode under the skin break. So if you think about 900 and some people, each of them have 4 implanted wires. And in that, so that's like 2,700 wires or whatever, I can't do the math. So whatever 900 times 4 would be, I think that's actually 36,000, 3,600. There's been 4 wires that have broken under the skin. So wire breakage that is a little more difficult to repair is very, very rare. As far as infection requiring IV antibiotics, we have not had to do that here at UH. We had one patient that was from Chicago that was getting kind of recurrent like abscesses in the abdomen. We pulled his wires out and then replaced them all in the same surgery. He's been pacing like that since 2010 without any other recurrent problem. So there's only been literally, I think, 2 people who have gotten, he was one that got IV antibiotics. People will get some antibiotics because there can be infection where the wires are tunneled. I know we didn't go into detail from the surgery, but these wires are kind of like tunneled, meaning they're threaded through the layers of skin for about 3 inches. And people can get infection along those where the wire track is. And that is usually very easily treated with a week of Kefsol or Bactrim or something similar. I don't know the numbers of how often I treat that. It does happen, but it's a lot more unusual in the spinal cord population than in the patients that are up walking around.
Well, thank you. If there's any last minute questions, you can go ahead and send them in. Otherwise, we'll log off here in another minute or 2. I just want to say thank you to all the speakers. You guys did a great job today, and we really appreciate your support and taking care of these patients and doing what's best for them.
And thank you for everybody who joined in to listen. You can contact myself I left it in the comments in the chat, but I will just add it again here. It's ctobos@synapsebiomedical.com. You can also reach Mary Jo. She left her phone number and email in there as well. And you can always reach us through our info box on our website. There's a contact us link. Other than that, it sounds like the questions are over. So have a great day, everybody. Thank you for stopping in, and we'll be talking with you soon. Thanks.